Hello, dear colleagues. My name is Ivana Bajkin. I come from the University Clinical Center of Vojvodina, and I'm an endocrinologist at the Clinic for Endocrinology, Diabetes, and Metabolic Disorders. Firstly, I would like to thank the organizing committee, and namely Professor Canic and Professor Bilic-Ćurčić, for inviting me to participate in this kind of meeting. I dare to say that Cushing's of any origin poses a medical problem and a great medical challenge, both in establishing the diagnosis, but also in deciding upon therapy. So they say that repetition is the mother of knowledge, of learning. So I will perhaps go through some of the information that Professor Vitek already has given us in his great presentation. Luckily for all of us that deal with patients with Cushing syndrome, there are new drugs that we can introduce. We are at the beginning of the era of using osilodrostat in Novi Sad, and we have some patients that I think would be eligible for this kind of therapy. So later on in the presentation, I will show you these patients. You've already heard that this is a drug that's been introduced for 4 years on the market, and it is effective. It has many trials showed it to be effective in all kinds of Cushing's. Nevertheless, the site of the tumor, osilodrostat will be effective in controlling hypercortisolemia. The recommendation from those trials is to start at 2 milligrams a day, but the dose can be gradually titrated for 1 or 2 milligrams in the course of every 2 to 3 weeks. More trials have shown that the mostly used dosage is somewhere between 2 or 7 milligrams 2 times a day. After several weeks, those patients that are treated with osilodrostat can show improvement in late-night salivary cortisol and in urinary free cortisol level. But we also can see later on that there are improvements in comorbidities. So systolic and diastolic blood pressure, A1C, body weight are all better after a few weeks. Of course, as with any other medication, trials showed some adverse events when patients use osilodrostat. There are several groups of these adverse events. So the first one is hypocortisolemia, and this is not a big problem. It can be easily solved by either omitting the drug for several days, or by reducing the dose for several days, or even by introducing hydrocortisone together with osilodrostat, so by using a block-replace regime. The other group of problems or adverse events is related to adrenal hormone precursors, and mostly patients are seen to have peripheral edema, to have arterial hypertension, and profound hypokalemia. Osilodrostat does not have to be omitted in these patients, but we should use concomitant medication to deal with such complications. Some small proportion of patients showed that osilodrostat has pro-arrhythmogenic capacity and that it prolongs QT interval on the ECG. So it's important for every patient that we consider for osilodrostat to obtain first the ECG and to check the QT interval. And after we start the patient on osilodrostat, we should do the first ECG control in 1 week and then periodically if everything is okay. And the last group of problems is related to tumor enlargement in patients that are treated with osilodrostat. Luckily, this tumor enlargement has been seen after a long period of time, after 72 weeks, as these studies showed. So the mechanism underlying this complication is still not well understood. In vitro studies showed that osilodrostat does not have any kind of effect either on ACTH level or in promoting tumor cell growth. So it can be this is due to the same problem we have after bilateral adrenalectomy in our patients, so something resembling Nelson syndrome. I will not go into details in all of these drugs, but these are the drugs that are concomitantly used in patients that have Cushing syndrome. So you can see that from atorvastatin to warfarin, every possible drug is on this list. Why is this important? Because osilodrostat and these drugs interfere with cytochrome enzymes in the liver, and they can change each other's levels in plasma. So we should think about some kind of adverse events that might occur during giving together these medications. Hypercortisolemia is sometimes life-threatening. So the cortisol level is so high that the patient is vitally endangered. In those cases, we can use, as Professor Whitaker stated, we could use block-replace regime, so we can start our patient on a greater dose than proposed 2 milligrams for the beginning, and at the same time introduce hydrocortisone to prevent deep hypocortisolism. And there are some authors that stated that in such conditions where our patient is vitally endangered, we can give etomidat together with osilodrostat, and then after several weeks we can stop etomidat when the cortisol level is controlled and leave patient only on osilodrostat for further therapy. So I already told you that we are on the beginning of the era of osilodrostat in Novi Sad, so these are the patients that I think would be eligible for such kind of therapy. The first patient is a female patient. She was 60 years old on the presentation, and she presented with all clinical signs and symptoms of the Cushing's. She told us that back in 2014, she underwent lower right lobectomy, and afterwards she received PE chemotherapeutic protocol. She was treated for lung carcinoma. You can see that she already had proven all the complications of the Cushing's, metabolic complications. So she had diabetes, dyslipidemia, osteoporosis, and even iliofemoral thrombosis. These are the laboratory findings in our patient. Her ACTH level was sky high. Our upper normal is 63. You can see that there is no diurnal rhythm in cortisol secretion and that there is a loss of suppressibility to dexamethasone. And late night salivary cortisol was very high also, together with NSE. We took the old tumor blocks back from 2014 and gave them to our pathologist for the revision, and they were positive for ACTH, even then in 2014. And our pathologist made a diagnosis of a typical carcinoid lung tumor. So you can see that her pituitary was normal. We felt that it was necessary to do the pituitary, although the ACTH level suggested ectopic secretion rather than pituitary secretion of ACTH. And we did the CT of the thorax and the abdomen, and there were newly developed nodules in the area of the scar after the previous operation. And there were some infiltrations in the liver that suggested metastasis. These are her stains for ACTH. We did the scintigraphy and proved that our patient, or the tumor of our patient, had somatostatin receptors on itself. So this patient, as any other patient with ectopic ACTH secretion, had very low performance status at presentation. So she was not eligible for chemotherapy, and we were obliged to control the severe hypercortisolism, and we introduced metirapino. Osilodrostat was not available in our country at that time. This is happening somewhere back in 2019, so we are not in the situation to give osilodrostat to the patient. And since the tumor had somatostatin receptors positive on the scintigraphy, we started this patient on octreotide as well. So I do believe that this kind of patient is an excellent candidate for osilodrostat therapy because we need prompt control of the severe hypercortisolemia. But I think that it should be emphasized that those patients that have ectopic ACTH secretion mostly have very profound hypokalemia at the presentation. So we should think about osilodrostat having the capacity to deepen that hypokalemia and always obtain in such situations potassium level first and then introduce osilodrostat. And the second patient is also a female patient. She's 57 years old, and also she complained about all the clinical signs and symptoms that were obvious for Cushing's disease. Again, we can see the loss of diurnal rhythm of cortisol secretion and a loss of suppressibility to dexamethasone, as well as the elevated ACTH. And she too, as the previous patient, had the metabolic complications of hypercortisolemia. We did an MRI to this patient, presuming that she has a ACTH secreting pituitary tumor, and we proved that there is that kind of tumor, but she was lost to our controls for 2 years. We made the diagnosis, and she wasn't available for follow-up. She reappeared 2 years later. We did a new MRI and saw that this tumor is a bit larger than it was back 2 years ago. So we referred her to neurosurgery, and this is her ACTH stain. So she had ACTH positive pituitary adenoma. First post-operative MRI showed that there were no signs of tumor, and her ACTH level was low together with cortisol, so she was put on hydrocortisone, and it lasted, the therapy with hydrocortisone lasted for about 6 months. She was okay in the follow-up for several years, and then in 2023, again, symptoms and signs of excessive cortisol level. So the laboratory once more showed that there is no diurnal rhythm, no suppressibility for dexamethasone in cortisol, and elevated late-night salivary cortisol together with ACTH that is on the upper limit of normal. So this is reoccurrence of the Cushing disease after 5 years of treatment. Pituitary MRI showed new tumor, so this patient was not interested in another surgery. She's not motivated for another surgery. And we are now trying to decide what's the best treatment option for this patient. We can talk about radiotherapy, but I think that we need to lower her cortisol level. She does not have a very elevated morning cortisol, but she is clinically profoundly Cushingoid, and she has all the complications. So I do believe that she needs therapy, and osilodrostat would be a reasonable choice. But since her cortisol level is not very high, I'm thinking about a lesser dose, perhaps to start with 1 milligram. And I saw that some authors reported even 1 milligrams every other day for such patients. So I think that that is something that we are going to try. And even we can talk about block replace regime. But I don't think the dilemma ends here. This patient might be a candidate for pasireotide. So this is something that needs to be decided upon. Thank you very much for your attention.